circulatory system. All these components make up the circulatory system. When we're talking about circulation, we mentioned how it comes in, right atrium, right ventricle, through the lungs, comes back out, goes to the rest of the body, through left atrium, left ventricle, and then out. Then it returns back in the vena cava and starts all over again. So one thing that goes associated with the blood flow and the circulation, of course, is when we're talking about peripheral vascular disease. So in turn, that's what we're going to be indirectly talking about. When we're talking about peripheral vascular disease, remember there's two sides of it. There's peripheral PAD, or peripheral arterial disease, or artery disease, however way you want to look at that. And then we have the peripheral venous disease. When we're talking about disease purposes wise, one thing that we're thinking about though is, even though they say PVD, why are you guys staring at me like that? It's 9:05. So if they're going to distract all of you, I will let them in. 9:05, girls.
Oh, no, I was because my watch.
So when we're talking about the peripheral vascular, keep in mind the V, there's also that venous side. The symptoms are different for peripheral vascular disease, arterial or venous, okay? So that's what we're going to mention right now. One, the PAD, or peripheral arterial disease, or artery disease, these patients have different symptoms than the venous side. So who knows or can tell me PAD, what are the symptoms?
Dry, hairless skin on the calf. The pulling.
Okay, so PAD, we're talking PAD. So they have no blood flow.
They have no hair growth on their calf.
No hair growth. Okay? What else, since you studied really hard?
I didn't say really hard. Neuropathy.
Okay? Well, you did. You said that. So, no pulses, hairless.
Do they have like that boggy feet or something?
They could have neuropathy. They have tingling, right? Pulses, no pulses.
Are they the ones that get the ruddy skin?
Poor wound healing.
Poor wound healing, which they do both have it, but for different reasons.
The ruddy skin, like the discoloration.
Pale, or if they're dark complected, darker skin.
Pale.
Yep, so lighter complected, pale, and then darker complected, darker. No pulses, we said. Cap refills in the toilet.
Do they have pain?
They have pain at rest. Pain at rest. So they're sitting there and their leg is just aching. Just pointing out legs is just easier that way.
And don't you want to dangle their legs off the side of the bed to try to get blood flow down? Or no, am I thinking of something else wrong?
Well, I mean, you don't want to put them above the heart, but you don't want them to dangle either, because there's nothing going to happen, because
Okay.
they're going to be occluded at the popliteal.
Okay, but you don't elevate.
You don't elevate. You keep them flat. But you also don't want to occlude at the femoral either, right? You wouldn't have them sitting high collars with their legs up either. So you want to make sure that that flow can get down is the goal. So on the venous side, a little bit different. One, they have what? Oh, let me back up, sorry. Also, they're cool to touch. PADs are cool to touch or cold to touch. Their extremity is not warm at all. Okay? Now we can flip to the venous side. Venous has what?
They get ulcers.
Blood ulcers.
They have venostasis ulcers, but so does the arterial side. The difference is that edema. So remember, it's the venous return, right? That's not happening. So it's not happening. So there is edema. Okay? They could have venostasis ulcers because the skin is stretched. That's what's end up happening with that. What else does the venous side have? Could have weeping wounds, yep. Because again, the swelling in the skin is stretched.
Bounding ulcers.
Bounding?
No.
Normal ulcers.
We hope.
Hopefully.
But how are we going to feel it through the edema? So they do have pulses, right? But the question is can we feel them? So both sides of the story is we need to make sure we have a Doppler. because we need to confirm that there's no pulse on the arterial side. But on the venous side, we got to get through all that fluid. What else?
Do you have that intermittent claudication?
That's the other side.
More varicosity,
What do you mean by that?
like varicose veins in my lower leg.
More popping out of those? Sure. What about pain?
No pain.
More of an ache. Their pain is all the time, or it's not really a pain per se, it's more of an annoyance because they have this swollen leg, right? And this pooling of blood. So it's not as painful as the arterial, but it's an annoying ache.
It's like a heavy ache.
It's like a heavy ache. Yep. Yep. So,
And would you elevate their legs then?
yes, you want them to remember the idea is to return it back to the heart. So you would elevate it above the heart. I saw a hand.
So they both have, PVD has pain all the time, but then PAD also has pain at rest, so they both have pain all the time.
But it's a different pain.
Okay.
So when we think of a pain, if you think of horrible pain, that would be that at rest for that arterial side. The venous side is more of an annoyance. Kind of like that nagging that won't go away. A lot more times that happens when they're up and about. Once they elevate and get that pressure off per se, and trying to return it back, usually that pain is decreased. It's not like the arterial side that it's a pain and it hurts. All of which the PVD as the big umbrella, vascular disease, is again caused by atherosclerosis. So you see the common areas where atherosclerosis happens. This is just a different view to see the plaque and the thrombus. Remember, cholesterol or plaque or lipids, however way you want to look at it, is horribly sticky. And so is your platelets, right? And so then it forms an occlusion, and that's where the problems begin. It can happen in the coronary arteries, it can happen in the peripheral vessels, and their cerebral vessels, I should say, and then of course at the feet, or legs, extremities-wise. So common places, anywhere there's a bifurcation, or a turn, or however way you want to look at that. So some of the common sites there. Popliteal is because it's bent. Femoral is because it's bent. When we sit, both places are bent. So more susceptible, of course, to those areas. Same thing with keeping elbows up, too. A lot of times it happens there as well. So modifiable, non-modifiable. So modifiable things that we can change per se. Non-modifiables, genders is associated with hormones, so that really should be kind of on both sides per se. One thing is the higher the estrogen, the more sticky the world is. So meaning that they're more susceptible to clotting. Increased estrogen, so contraceptives, oral contraceptives, and then hormonal replacement therapy, more susceptible to clotting. Then all of that also plays a role. With the tobacco and the nicotine idea, small vessel disease. So now you have smaller vessels more susceptible to the stickiness of the world with the lipids, and then you throw the diabetes in there. So all of that plays a role. Medical management, of course, it's always going to be prevention first. Exercise regimens. One, the thing is with arterial, how are you going to get them to exercise? They won't be able to feel, they have no pulse, and they're walking pretty much on a non-oxygenated extremity. Okay? But for the venous return, that would help, as long as it doesn't get to the point of the stuff mentioned with the venous stasis ulcers and the barely being able to feel the pulse. Even though they will have it, it's just going to be hard to feel. That, again, why you have to get Dopplers. So 2 of the medications that are associated with peripheral vascular are listed there for you already. The use of other medications like antiplatelets, aspirins, Plavix that we mentioned. Surgical management is another for the arterial side of the world. Arterial will have what we know as a femoral popliteal bypass graft. If a patient says that they've had a FENPOP and they're not on anticoagulants, that is probably a good sign that their leg pain is associated with their lack of anticoagulants as a whole. So they're gonna be more susceptible to clotting again and maybe losing that leg. A lot of times when patients say, it's usually like 5 or 6 o'clock in the morning and we get the call from EMS that's bringing in a patient. And we had a African-American woman that came in, it was about 5:45 in the morning. And when you took the blanket off of her legs, you could see where she had the bypass and where she didn't. Because this one was darker, toes were horrible, it was horribly sad. And so you asked her for her medication list, so we had to call her son. And we asked if she was on anything that started with a W, like warfarin. And he's like, yeah, she hasn't had it filled in 3 months. So she ended up losing her leg that day. So it was sad. So, but you can definitely see the difference. With PVD, you're like, oh, there's some swelling, there's some this, there's some that. Oh, look. But that, it was her right extremity, had no pulse whatsoever. None whatsoever. So she couldn't sleep because her pain was so bad. But like I said, she ended up losing that leg that day. So definitely a significant difference with the symptoms. Yeah.
What does a pentoxifylline do for PVD? Because that's for like breathing, isn't it? Like theophylline?
What is?
The pentoxifylline?
No, it's Trental.
So that's not
Trental.
the same class as like the theophylline?
No,
Okay.
it's not. No, theophylline is a bronchodilator. That is not a
Okay.
bronchodilator.
I was getting them, I thought they were together, that's why I was confused.
Yep, nope. Nope, Trental is a very popular drug for peripheral vascular. Aneurysms. 2 different types. We're not going to spend a lot of time on these. It's just more for informational purposes too. Of course testable, but the thoracic aortic aneurysm is one, and then abdominal aortic aneurysm. So different aneurysms, just want to show you pictures. There's different types. I don't want you guys spending time memorizing this. But just know that there's different types, all of which are susceptible to dissection. Dissection is a fancy word to say leaking. Okay, that is a fancy word. So when you have an aneurysm that dissects, that means that it's leaking out into that cavity. Okay, whether it's the aortic or the thoracic aortic or the abdominal aortic. In patients who are very thin, when you go to listen to bowel sounds, you very well may hear a pulse because they're thin, 6-pack stomachs, things like that. But it's not normal in an everyday life to have a chubbier patient that you hear a pulse when you're listening to bowel sounds. And so they will have symptoms of such pain in that cavity, and then their blood pressure will be. The lower the blood pressure, the worse off the dissection. Because as it's leaking, it's losing, you will get the tachycardia for temporary. And then once they leak and it's fully dissected. So, emergency surgery. So here is the aortic, just a visual of what they do for the aortic graft implant. Is they open and you can see the bulge. They open it up, they put the graft in, and they close it up. Again, because it's heart surgery, you have the patient that looks the same as what your cardiac patient did of that cardiac bypass. So same kind of patient with the head to toe stuff going on. So critical patient, we want to make sure they stay hemodynamically stable and there's no, for lack of a better word, leaking, or the graft stays intact. Questions about any of that? So this test